you a bit about acute rheumatic fever and then about rheumatic heart disease. It used to be that rheumatic heart disease was the most common acquired form of heart disease in children, particularly in developed countries, but now that has been replaced by Kawasaki disease, which I'm going to be talking about second. So acute rheumatic fever is a disease that's a reaction to the group A streptococcus. So this is a gram-positive extracellular bacterium that can cause suppurative infections, such as most commonly we know it as group A strep or tonsillopharyngitis, but it can also cause skin infections, such commonly in kids, such as impetigo. And in rare circumstances, it can actually cause sepsis and toxic shock syndrome. Some of the non-suppurative sequelae are things like acute rheumatic fever, post-streptococcal glomerulonephritis, and reactive arthritis. And we're going to be focusing on acute rheumatic fever. So acute rheumatic fever usually is a delayed response occurring 1 to 5 weeks after someone has a pharyngitis with group A strep. And it's an autoimmune sequelae, and it has a number of manifestations, with arthritis being the most common, followed by carditis, which is the most severe, and then chorea, which is a movement disorder, has the latest onset, and then a particular type of rash called erythema marginatum, which is the rarest manifestation. So it has a peak incidence in 5 to 14-year-olds, and about 0.3 to 3% of group A strep pharyngitis will develop acute rheumatic fever. So there's 336 annual cases, 95% of which are occurring in less developed countries. And of those who develop acute rheumatic fever, 60% will go on to develop chronic rheumatic heart disease. And this might actually be higher if we include subclinical disease, which is now being found on echo screening, particularly in developing countries. So it is a disease that is seen worldwide. Rheumatic heart disease affects about 2.4 million children and up to 19.6 million people of all ages worldwide. 79% of cases of rheumatic heart disease occur in less developed countries, and in those countries, it's the #1 reason for cardiac hospitalization. So the prevalence rate per population is much, much less in developed countries than in less developed countries. So why do some kids who have a group A strep throat develop rheumatic fever or rheumatic heart disease, and not everyone? Well, it's an interaction between both the organism itself, the group A strep organism, environmental factors, and then factors of the patients themselves. And it's an interaction between those three components. So we'll first talk about the pathogen. So group A streptococcus comes in more than 100 serotypes, and the serotype that we're interested in is the serotype that causes tonsillopharyngitis. And one of the components of the group A strep serotype group X is that it has an M protein that makes it much more infectious and virulent. And if the M protein is a class 1 type M protein, that leads to rheumatogenic features. And if it's a class 2, they develop post-streptococcal glomerulonephritis, which is often more commonly seen not after a strep throat, but after a streptococcal skin infection, such as impetigo or erysipelas. So that's the pathogen factors. What about host factors? Well, there may be familial or genetic susceptibility in that certain HLA class 2 alleles may predispose someone to react to a strep infection and develop acute rheumatic fever. It's certainly very prevalent among certain ethnic groups the Maori in New Zealand, the Aboriginal population in Northern Territory, Australia, and Samoans in Hawaii. And we do see it somewhat in our Inuit population in Northern Canada. Some environmental factors include crowded conditions, such as crowded in terms of housing or crowded together as in the military. Therefore, it tends to be much more prevalent in urban settings than rural settings. It has a late winter and early spring peak, which is the peak for group A strep pharyngitis. And it tends to affect people in lower socioeconomic strata who have poorer access to healthcare and don't get their group A strep infections treated, or have poor nutrition that make them more prone to develop group A strep infections. So those three factors interact: the environmental factors I just described, geography, socioeconomics, and season, and then they interact with host factors, which include genetic and familial factors, and then pathogen factors, which include the serotype of and the M protein type of the group A strep infection and the site at which that infection occurs. And that leads to acute rheumatic fever, the interaction of those. So this is some of the microbiology, the pathophysiology behind group A strep pharyngitis, and how the activated T cell interacts with the M protein, the one that puts you down the rheumatic fever pathway, to upregulate cytokines and lead to a more inflammatory response. And this M protein is structurally the same as myosin, which is why it leads to myocarditis and carditis, and to laminin and keratin, which are components of the endocardium. So there's a cross-reactivity between the antibodies to that M protein and these structures in particular, which gives the predisposition to carditis. So unfortunately, there's no single sign, symptom, or lab test that you can do to make a diagnosis of acute rheumatic fever. And I'm going to say the same thing when I talk about Kawasaki disease. And so we're left with having to make a clinical diagnosis using something called the Jones criteria. But we can also use supportive evidence that comes from our testing, which includes the chest X-ray, the ECG, and the echocardiogram. So to make a diagnosis, these are the Jones criteria. You have to have at least 2 major or 1 major plus 2 minor manifestations, plus evidence of an antecedent group A strep infection, either through culture or through serology. So the major manifestations include carditis, polyarthritis, Sydenham's chorea, which is a movement disorder, a particular rash called erythema marginatum, or the presence of subcutaneous nodules. And then the minor manifestations include arthralgias, just painful joints without them being inflamed, fever, an elevated SED rate or CRP, elevated inflammatory markers, or the presence of a prolonged PR interval on electrocardiogram. Now into this mix in areas where we know that rheumatic fever, the prevalence of rheumatic fever is much greater and is more endemic, we can also add in echocardiographic features that may suggest carditis. And in particular, the one that we pay attention to is mitral valve regurgitation. And we'll talk about the valves being affected in rheumatic fever. So if someone has acute rheumatic fever, the first thing to do is to eradicate the group A strep infection with penicillin, and then to provide supportive care for the clinical manifestations of acute rheumatic fever. So for arthritis and carditis, we give anti-inflammatory agents. For the carditis, sometimes we recommend bed rest to decrease cardiac work and the stress on the heart, and in particular the valves. And in situations where you have severe carditis and severe valvar involvement, surgery may be indicated if the patient has intractable congestive heart failure. But in addition to treating acute rheumatic fever, we also need to prevent further episodes of acute rheumatic fever. And in order to do that, we have to eradicate the primary infection and then prevent them from having further group A strep infections, which further stimulate that immune response that attacks, in particular, the heart. So we give antibiotic prophylaxis, and it's of varying durations depending on the degree of carditis that the patient has, and may actually in some patients be lifetime. So the acute cardiac manifestations is when you have acute rheumatic fever is a pancarditis, which is a misleading term because most of the carditis is actually really an endocarditis. And that's why the valves are primarily involved. And it becomes the major source of morbidity and mortality in rheumatic heart disease. Less so, the myocardium and the pericardium can be affected. Usually these manifestations appear, the cardiac manifestations appear within 3 weeks of the acute episode of the strep infection. And this is pericarditis, where you can see a serofibrinous exudate. Clinically, you might hear a friction rub. You might see an effusion on an echocardiogram. The patient might complain of specific chest pain. And there are a number of ECG changes that are very specific to pericarditis. The problem with the friction rub is that it may obscure the presence of a murmur, which may suggest an underlying valve problem. However, with the pericarditis, there's no long-term morbidity, but keep in mind that it never occurs in isolation. Usually there's endocardial involvement as well. The myocarditis that occurs is really an inflammatory myocarditis in that there's no myocyte necrosis or destruction like you might see in viral myocarditis. But they develop these particular bodies within the myocardium called Aschoff bodies, which are somewhat pathognomonic of someone who's developed rheumatic heart disease. Clinically, the patient may develop some cardiomegaly, but the cardiac function tends to be normal. And it's usually not the cause of heart failure in the setting of rheumatic fever, and it tends to cause no long-term sequelae. But the valvulitis is the thing that really is the thing of importance for acute rheumatic fever. And it's unclear why the valves in particular are affected, whether this is more a specific immune system target, and whether there's chronic infection that helps to drive that immune response that further damages the valves. But it's the major cause of morbidity and mortality in rheumatic heart disease. And it can be subclinical in that there may be no murmur, but when we look on echo, we see some mitral regurgitation that indicates valvular damage that may be subclinical and silent. Of the valves that are involved, the mitral valve is the most commonly affected, followed by the aortic valve, and very rarely is the tricuspid valve, and even more rarely is the pulmonic valve affected. The valvulitis tends to be manifested by valve regurgitation or insufficiency in about 50%. And in another 25%, they develop obstruction of the valve in addition to leaking of the valve. And sometimes it's this obstruction of the valve, particularly of the mitral valve, that can become a chronic feature. And the reason why the left side is much more likely to be affected than the right side is that there's higher shear stress and higher pressures and greater risk for trauma in an inflamed valve. So we can, at the time of acute valvulitis, we can actually see vegetations along the closure lines, usually of the valve, usually along the atrial side of AV valves or the ventricular side of arterial valves. It's rare for these to extend to the chordal apparatus, but if they do, sometimes it can cause the cords of the valve to rupture, and that leads to florid mitral regurgitation and congestive heart failure. Now, that's the acute manifestations, which if you've treated the patient early in the course and tamped down both the immune stimulus in treating the group A strep infection and tried to reduce the inflammation, hopefully they won't progress to chronic manifestations, which is where the valves come in. And these are progressive, related to ongoing inflammation and scarring. They definitely worsen with recurrent attacks because the immune damage gets reactivated and causes irregularities of the valve that increase the risk of endocarditis and possibly even thromboembolism. And the lesions that are most commonly seen in the chronic manifestations are mitral stenosis, then mitral stenosis plus regurgitation, then aortic regurgitation, and stenosis of the other valves or regurgitation of the other valves is relatively rare. So you're looking at mitral stenosis, and this is a patient where you can see the mitral valve on the far right hand of the screen, that the leaflets are very thickened and fused together. You also would see that the cords of the valve are shortened, and this leads to the mitral stenosis, which causes the left atrial pressures to back up into the lungs. You get increased pulmonary venous pressures, and eventually pulmonary hypertension, which backs up further into the right heart, leading to right heart failure. So the management of mitral stenosis is to open up that mitral valve. And nowadays, balloon valvuloplasty has become the most popular way to do this. However, it is associated with a 16% chance of restenosis. And having a favorable morphology to the valve means that you'll get a better response to the valvuloplasty without creating, you may relieve the stenosis, but you may tear the valve and lead to regurgitation. If the patient requires a valve replacement, you can consider putting in either a tissue valve or a bioprosthetic valve. So mitral regurgitation is also a common lesion. And with chronic mitral regurgitation, the heart can compensate up to a point until left atrium dilates and may further stretch the valve and cause more regurgitation, and eventually leads to ventricular dysfunction, dilatation, and heart failure. So we treat mitral regurgitation if it's symptomatic and have normal valve function. We might treat it medically, but if it's more than that and the patient has intractable symptoms, we might proceed to just like with stenosis, to a valve replacement, considering either a tissue or a prosthetic valve. Isolated aortic stenosis or aortic lesions in rheumatic heart disease are really rare, less than 3%, and more often regurgitation rather than stenosis. And this regurgitation can be compensated for many years until the patient develops systolic dysfunction of the ventricle and then symptoms of heart failure. So that's a quick overview of acute rheumatic fever and acute and chronic rheumatic heart disease. It's very rare for us to see a case at Sick Kids these days, but when we do, we're always plugging the patients in for long-term follow-up. So I'd like to finish with 5 multiple choice questions. So you can just I think you can just answer these in your head. We should have set these up as Zoom questions, which we can do for the next time we have this course. So what percentage of patients with acute rheumatic fever will develop rheumatic heart disease? 20, 40, 60, or 80%? So the answer is 60%. 60% of patients with acute rheumatic fever develop rheumatic heart disease. Which of the following is not a risk factor for the development of acute rheumatic fever? So a group A strep skin infection, decreased access to healthcare, genetic susceptibility, or malnutrition. So the answer is the group A strep skin infection, which is much more likely to cause post-streptococcal glomerulonephritis rather than rheumatic fever. And the other three are some of those pathogen and there's host and environmental factors that contribute to acute rheumatic fever. So which of the following patients fit the Jones criteria for diagnosis of acute rheumatic fever? So first is arthritis, carditis, and a positive group A strep serology. Chorea together with an increased SED rate or increased CRP. The presence of subcutaneous nodules plus group A strep serology plus mitral regurgitation. And then the final one is arthralgia, fever, prolonged PR interval, and an increased SED rate. So the answer is the first one, where we have two major criteria plus evidence of a group A strep infection. So group A strep infection is one of the chronic ones. So remember, you could have two major or one major and a number of minors. So what is the most common site for valvulitis in rheumatic heart disease? Is it the aortic, tricuspid, mitral, or pulmonic valve? So the answer is the mitral valve by a long shot. And then finally, which is the most likely location for a valvular lesion in rheumatic heart disease? Thinking more about those, possibly even those vegetations. So is it on the ventricular side of the tricuspid valve, the tendinous cords of the AV valves, the atrial side of the semilunar valves, or the ventricular side of the aortic valves? So it's the ventricular side of the aortic valve. So it's the left side, first of all, and it's always on the face of the direction of blood flow. Okay, so I'm going to stop sharing for a minute and ask if there's any questions before we move on to the next talk.
There's nothing on the chat in terms of questions.
Okay, so I'll move on to another disease that's a bit of an enigma, but a little bit more common and something that we see lots of at sick kids. And that's Kawasaki disease. So Kawasaki disease is a disease that was first described by Dr. Kawasaki in Japan in 1967. And Dr. Kawasaki actually just passed away within the last year, and I got to meet him, fortunately, on several occasions. And he was really just a general pediatrician who put together a bunch of cases that he was observing in his practice in Japan. Kawasaki disease is an acute, self-limited inflammatory disease that affects the small and medium-sized arteries of the body, specifically with a predilection for the coronary arteries. And if we don't get it and treat it in time, within 10 days of the onset of fever, up to 25% of children will develop coronary artery aneurysms. If it's treated appropriately, and treatment is with intravenous gamma globulin, that reduces down to about 5% will develop aneurysms, with about 1% developing what we call giant aneurysms. And it's this coronary artery aneurysms that are the real morbidity for patients who have had Kawasaki disease, since it can lead to myocardial infarction, sudden death, or ischemic heart disease. So we've been tracking the incidence of Kawasaki disease in Ontario and more broadly across Canada for many, many years. And for a while, we thought that it was the incidence was increasing, but it seems to have plateaued at about 25 to 30 cases per 100,000 children less than 5 years of age per year. It's definitely has an increased risk among people of Japanese, Asian, and Pacific Island background. So I can tell you in my Kawasaki disease clinic, I'm probably one of the biggest users of interpretive services with people that are speaking Mandarin, Cantonese, Japanese coming in. It has a predominance that's greater in males than females. The peak incidence in terms of age is 1 to 2 years, but can occur in infants less than 3 months and in kids older than 8 years of age. It is rare, but it can be seen in families. There's an increased risk in siblings, twins, and offspring of patients who've had Kawasaki disease, but since it's rare to begin with and it is a bit increased in families, it's still rare. The risk of getting it more than once is extremely low, but greater than in the general population. And it has a increased prevalence in winter and early spring, particularly in our region. However, now that we've known about Kawasaki disease now for almost 50 years, the cause of Kawasaki disease still remains unclear. Whether we think that it's some sort of infectious or environmental trigger that in certain patients who are either genetically or developmentally susceptible to develop this pathologic immune response that gets manifested as Kawasaki disease. And we have identified a number of particular genes that imply a susceptibility to Kawasaki disease, particularly in Japanese and other Asian cohorts. And these are all genes that have to do with inflammatory pathways. The underlying pathology of Kawasaki disease is that it's a generalized vasculitis that nearly always affects the coronary arteries, but can affect arteries in other parts of the body, particularly in the abdomen and in the femoral iliac in the legs and the axillary brachial in the arms. And at autopsy, this is a picture where the arrow is pointing to a giant coronary artery aneurysms in the left main coronary artery branch. And it's probably the reason why the patient died is because the aneurysm is probably completely filled with clot, which is the leading cause of death in someone who has an aneurysm. Now, in the long term, these aneurysms can actually heal by developing, they don't really shrink down. Layers and layers of fibrous tissue can build up. Someone needs to mute.
Yeah, I'll mute just a second. Okay. There we go.
Okay.
Yeah.
So we call this proliferation luminal myofibroblastic proliferation, and it actually leads to stenoses in the long term. And then if you look on the other side, you see a coronary artery aneurysm where there's a big clot sitting in the middle of it, which is another reason why kids might develop a heart attack. So this is sort of the natural history of coronary artery involvement, where the vast majority of patients will have no coronary artery changes, and a smaller proportion of them will have some dilatation where the coronary may be bigger than normal in the acute phase, but it quickly resolves. But some patients develop what's called a necrotizing arteritis, whereby the structure of the vessel itself gets attacked and destroyed, and under hydrostatic pressures, it causes the arteries to balloon out. And then you can see a pathway whereby you develop the scarring, which leads to narrowings, or they have a clot, which can recanalize and lead to narrowings as well. So I mentioned that we don't know what causes Kawasaki disease, and we also don't have a single test, just like rheumatic fever, to tell us whether someone has it or not. So just like the Jones criteria, we have criteria for making a diagnosis of Kawasaki disease. So these include fever for 5 or more days, and the presence of 4 or more of extremity changes, erythema, edema, desquamation of the hands and feet, a rash, red watery eyes without them being pussy, changes in the lips and the oral cavity, strawberry tongue, dry, cracked red lips, and then swollen neck nodes, usually unilateral. So if there's some evidence of coronary involvement, however, we can make a diagnosis of something called incomplete Kawasaki disease, where they don't have all the usual features. So this is some pictures which the hand, and then on the right-hand side, the desquamation, which tends to start right around the nail bed and then spreads, which is somewhat pathognomonic for someone who's recovering from Kawasaki disease. And then a rash, which can be polymorphous and diffuse, but not with blisters. And then the conjunctival injection, which is bilateral. There's no pus to it, and it's painless. Here's a picture of what we call the strawberry tongue. And then the cervical lymphadenopathy, which sometimes can masquerade as actual lymphadenitis, an infection of the lymph node. And some patients actually get surgery on these lymph nodes before the diagnosis of Kawasaki disease is made. And of course, we need to talk about the cardiac findings. So just like rheumatic heart disease, the cardiac manifestations of Kawasaki disease is again a pancarditis in the acute phases, where they can have inflammation of both the pericardium, the myocardium, and the endocardium, and also the coronary arteries as well. The myocarditis is only seen in the acute phase, and in quite rarely can cause decreased ventricular function, but with appropriate treatment, anti-inflammatory treatment, it resolves with no real sequelae. And they can also develop some mild dilatation of the aortic root, or mild aortic or mitral valve regurgitation, again, which are not really of much sequelae. Some of the other manifestations that can happen during the acute phase are gastrointestinal, vomiting, diarrhea. High drops of the gallbladder is an unusual finding and might be specific to Kawasaki disease. They can have inflammation in the genitourinary system, arthritis and arthralgias, and they can have inflammation in the neurologic system, which leads to marked irritability, and some rare findings such as sensorineural hearing loss and facial palsy. Now, 25% of cases do not meet the typical criteria, which I described at the very beginning. And incomplete cases, meaning those with less than 4 of the diagnostic criteria, the most frequently one that's missing is the cervical adenopathy, followed by the rash, and then the extremity changes. And these incomplete cases are most commonly going to happen in kids who are very, very young, at the lower end of the age range at which people typically get Kawasaki disease. And for those with incomplete criteria, it may be difficult to make the diagnosis. And so we develop algorithms whereby we can incorporate additional laboratory features that will help us to differentiate who needs an echocardiogram and who needs to be presumptively diagnosed and then treated acutely. So these are some of these laboratory features, which include a high white cell count, anemia, markedly elevated inflammatory markers. Patients, particularly when they're starting to come out of the acute phase, can develop extremely high platelet counts, sometimes more than 1 million. They can have abnormalities in their cholesterol levels, low levels of serum albumin, which are often associated with more severe disease and a greater likelihood of developing coronary artery complications. And sometimes they can have inflammation in the liver with elevated liver enzymes. So the primary imaging modality for assessing the heart is echocardiography, and it should be performed as soon as the diagnosis is suspected. And if the echo is of a poor quality because sedation could not be administered, then the study needs to be repeated under more optimal circumstances after the patient has been treated. And the initial study establishes a baseline for how things are going to change as you follow them over time. So here's an example on the left of what would be a normal left coronary artery coming off the aorta. And if you look on the right, you see what is a giant aneurysm, the diameter of which is indicated by the two crosshairs. And that's kind of how we measure and see the aneurysms on the echocardiogram. We can also see them on angiography, which we tend to do much less frequently these days. So on the left is a large aneurysm you can see in the left anterior descending. And in the right-hand panel is a giant aneurysm in the right coronary artery. And actually you can see it's like a whole string of beads where there's multiple aneurysms. Sometimes the whole artery can be aneurysmal, and we call that a fusiform aneurysm. So how do we treat Kawasaki disease in order to mainly prevent these cardiac complications? Well, we should make the diagnosis and start treatment within 10 days of the onset of fever. And the primary treatment, and it hasn't changed for a long time, is to give high-dose intravenous gamma globulin infusion. And we also use high-dose anti-inflammatory doses of aspirin, although this has been recently shown not to be as effective, and therefore we may just start with lower doses of gamma globulin. Other therapies might be given, anti-inflammatory therapies might be given to patients who we think are at high risk for developing aneurysms, or who might be high risk of not responding to the initial dose of gamma globulin. And now we tend to be using a lot more steroids and biologic agents such as infliximab or etanercept, and another one we used recently is anakinra. We tend to use these very rarely, but we do tend to use steroids a bit more commonly. And as I mentioned, some patients, you give the gamma globulin and they either continue to be febrile or they quickly redevelop their fever. And this occurs in approximately 10 to 20% of patients who have KD. And it may be a marker that they have more severe KD and are therefore at increased risk for developing coronary artery aneurysms. So we would treat that by sometimes we just give them another dose, another course of gamma globulin. Sometimes we give them another course of gamma globulin, but also give them steroids at the same time, and maybe continue that for a few days. Another medication that may be used, another anti-inflammatory agent, is infliximab. We don't tend to use this that much at sick kids. We tend to rely more on longer doses of steroids. So highly inflamed patients who fail to respond to all of that may be going on to more advanced therapies, which include cyclosporin, anakinra, cyclophosphamide, and in Japan, they have used plasma exchange to some benefit in selected patients. One of the things you have to remember when you're treating patients with IVIG and gamma globulin, when you're using or IVIG and aspirin, there's always the risk of Reye's syndrome. So if they have been exposed to varicella or influenza, then we need to switch them over to something besides aspirin. And they should have make sure they get their influenza shot, their flu shot. And for those who got gamma globulin, since the gamma globulin injects them full of antibodies, they may not, if you gave them a live virus vaccine, the vaccine may not take as well. And so you want to put off certain vaccinations for 11 months until the gamma globulin is cleared completely out of the system. However, you can give some of these vaccinations and they will have some effect, but not complete effect. And if you do that, then once the IVIG waiting period is over, you need to give them a booster. So the patients who have no coronary artery involvement or dilatation only likely are at risk for nothing in the long term in terms of their heart. And a lot of those patients we just discharge. But those that have coronary artery aneurysms, we're going to be following them for their lifetime. And we do this with echocardiography, normalizing the measurements of the coronary arteries to their body size to look for changes in bodies in Z-scores related to their body size. Now, many other, we can classify coronary artery aneurysms by the size and then how much they decrease in size over the long term. So the highest level of risk is those who have large or giant aneurysms, which means they have a Z-score above 10, which is extremely outside of the normal range. And then we subclassify them according to whether the aneurysms have started to decrease in size over time. And that determines how often we follow them and also some of their medical management as well. Now, there are a number of other features of the aneurysms that we take into account that may also further increase the risk besides just the size of the largest aneurysm, including such things as the total number of aneurysms, the number of branches involved, and then whether they had a previous clot in their coronary artery aneurysm. So long-term management begins at the end of the acute illness, which is usually 4 to 6 weeks after the start of the fever and all the signs and symptoms have resolved. And by that time, the aneurysms have usually reached their maximal limit. And then the goals of long-term management are to prevent the clots and the ischemia that lead to heart attack in these patients. So some of the things that we consider in the long-term management is how often do we need to see them for follow-up? How often do we need to do stress testing to make sure that the blood is getting freely through to all the different parts of the myocardium? What advanced cardiology assessments might we need to use? Things like CT scan, MRI, and even angiograms to look at the coronary arteries. We need to think about assessing for other risk factors and making sure they're in check, things like hyperlipidemia and hypertension. Promote physical activity, except in those who need a precaution if they might be on anticoagulant therapy. Counsel about reproduction and pregnancy, and then have a strategy for preventing clots that's calibrated to the size of the aneurysms. And so guidelines were put out from the American Heart Association, which does these exact things. I don't expect you to see this, but these are the guidelines according to the size of the aneurysms and where they decrease to that determine the frequency of cardiology assessment, stress testing, and advanced tests. So it's reasonable to use stress echo, or we in our institution we use exercise echo, or we can do stress testing during MRI to look at the risk for ischemia. And MRI has really been a useful thing because it avoids radiation exposure. It also allows you to look at the myocardium at the same time, to look at how well the heart is squeezing, we can look at perfusion, and we can also look at if there's any areas of scar. And we can also look at things like myocardial edema, but it's really the perfusion thing that really is the useful part for the cardiac MRIs for us. Now, in addition, these patients may need medical therapy as well, including low-dose aspirin is usually a chronic thing in someone who's had coronary artery aneurysms. We have to use anticoagulation for those who have large or giant aneurysms, and that can include warfarin or low molecular weight heparin in order to prevent the clots that can lead to acute myocardial infarction. When aspirin is not enough and anticoagulation is too much, we could consider using 2 antiplatelet agents, which is where aspirin and Plavix may be considered. And then some patients, particularly those with large aneurysms, may be indicated to be put on a beta blocker, and statins have been used to try and manage some of that proliferative remodeling that happens, the LMP process that I previously talked about. So that's a quick overview of Kawasaki disease. And again, I have 5 questions for you. So I'll read them out, and then you can sort of guess as to what the answer might be. So which of the following is true regarding the etiology and epidemiology of Kawasaki disease? So first, it's inherited disease. Second, an infectious cause is suspected because you usually have multiple cases within a family or daycare center. And then an infectious or environmental trigger initiates an extreme immune response in susceptible children. KD is most common in children between the ages of, I think it's 5 to 10. And then the male to female ratio of KD is 1 to 2. So the correct answer about the etiology is number 3. The infectious or environmental trigger in susceptible children prompts this extreme immune response. So it's not an inherited disease. It's not infectiously mediated through a family or a daycare center. It's most common between 1 and 5 years of age. And actually the male-female ratio is 2 to 1. Next, which of the following makes the diagnosis of Kawasaki disease? So 5 days of fever plus conjunctivitis, oral changes, enlarged neck nodes, and erythema of the hands and feet. 4 days of fever plus conjunctivitis, mouth changes, and enlarged nodes and erythema of the hands and feet. And then 5 days of fever plus oral changes, nodes, red hands and feet, and coronary artery abnormalities on an echo. And then 5 days of fever plus oral changes, nodes, hands and feet, plus a positive strep throat culture. So actually, a lot of these ones could hit that criteria. So, but the one that is the most iffy is number 5, in that you have fever plus only 3 criteria. If there were some additional laboratory criteria that were present, you could potentially make the diagnosis of incomplete Kawasaki disease in that patient. So which of the following laboratory findings is not consistent with Kawasaki disease? So a normocytic anemia, elevated liver transaminases, decreased ESR levels, elevated CRP levels, and elevated platelet count. And the answer is decreased ESR levels. The ESR level, another inflammatory marker, actually would be extremely high. So which of the following is correct using the acute management, regarding the acute management of Kawasaki disease? So first, steroids are the first line treatment for Kawasaki disease. Non-steroidal anti-inflammatories are often used in the acute management of KD. IVIG ideally should be given within the first 10 days of the illness. And then aspirin should be stopped after 5 days of initiating treatment of Kawasaki disease. So the answer is number 3. IVIG should be given within the first 10 days of the onset, and that's the first line of therapy. Steroids are really a second line treatment. Non-steroidal anti-inflammatories have a role if the patient really has arthralgias and arthritis, and aspirin should be continued at least for 4 to 6 weeks after it's started in the acute phase. And so this is the most recent guidelines that were published in by the American Heart Association in 2017. And so most of this that I've talked about are compliant with those guidelines. Okay, so if there are any questions or comments?
No questions at this point. Let me just chat again.
What was the answer on the second question?
What was the answer on the second question? Was that what you were asking?
Yeah, what was the answer on the second question?
Okay, well, let me see if I can pull it up again. Yeah, so which of the following makes the diagnosis of Kawasaki disease? So the first one is 5 days of fever, plus they have red eyes, oral changes, nodes, and erythema of the hands and feet. So they actually have 5 days of fever plus 4 of the 5 diagnostic criteria. So they would be definitely diagnosed. 4 days of fever, you probably need to have more criteria, but this patient had conjunctivitis, oral changes, nodes, and erythema of the hands and feet. So had 4 days of fever plus 4 out of the 5 criteria. So usually you want to wait until they have 5 days of fever, but an experienced person who sees a lot of Kawasaki disease can make that diagnosis early. And that's a good thing because then you can treat early and you have a greater chance of preventing the coronary artery complications. So the next one is 5 days of fever plus oral changes, nodes, red hands and feet. But this patient also has coronary artery abnormalities on echo. And so once you have coronary artery abnormalities on echo, it doesn't really matter how many criteria you have, you most likely have Kawasaki disease. Because there's very few things that can give you an abnormality of the coronary arteries on an echo in the acute phases. And then the last one, 5 days of fever plus oral changes, nodes, red hands and feet, but a positive strep throat. Well, that's 5 days of fever plus only 3 criteria and a laboratory feature that really is unrelated to Kawasaki disease. So this is a patient who, if they had other lab criteria such as anemia or low serum albumin or raised liver enzymes or extremely high CRP or ESR, that might cause you to make a diagnosis of incomplete Kawasaki disease. So potentially all 4 of these could have met the criteria for the diagnosis of Kawasaki disease.
Thank you.
Okay, any other questions?
Just congratulations.
Okay.
Thank you so much for sharing two really excellent presentations on acquired heart disease.
Okay, great. Thank you very much.
Bye.